little bit of a recap. Okay. What are the three components of the perfusion triangle? The pump, the ice, and the fluid or the volume. And it's not just blood, right? So, we talked about two different kinds of shock already. What are they? Hypovolemic, cardiogenic, which is the pump, right? You can't do it without your heart. Hypovolemic is broken up into two different types. What are they? Hemorrhagic and non. You're either bleeding or you ain't. Alright, so distributive shock. There's three different types. Here is the entire basis of this. Fluid is distributed where it ain't supposed to go. There it is. Dot, period. Now, why is it being distributed where it ain't supposed to go? There's two different reasons. Stay with me. So, everybody has heard of sepsis, septic shock. Everybody probably in clinicals is going to see this. This kills a lot of our patients. What happens in sepsis? Somebody tell me what happens. You get infection. It's in your bloodstream. Somebody tell me, who just said it? Inflammatory markers, right? What gets released? Cytokines. Starts with an H. Histamines. Cytokines. What do those have an effect on? The vessels, and they make them start what? And leaking. And your fluid gets distributed elsewhere. They call it third space. What you laughing at? I don't know what she's laughing about, but it was funny.
She laughs a lot.
Okay. So you have an infection. Anytime you have any infection, inflammation, it is an insult to the system. So if you have a little localized infection, it gets red, it gets inflamed. So the blood, a lot more blood flow goes to there, and it releases histamines, it releases a little bit of cytokines. So why do we get septic? We don't really know. Your body goes stupid, and it gets this massive inflammatory response. A lot of cytokines, a lot of histamine, and it affects the capillary membranes, and they become permeable. All your fluids are distributed into the third space. Have y'all heard that? Oh, your patient's third spacing. And you go in there and they look like the Michelin Man. Or if y'all have seen, what movie is that? It's old and I'm fixing to show my age.
Flubber?
It's a Christmas movie. You'll shoot your eye out, kid, and he's walking and he's out.
I can't move my
Yeah. They really look like the Michelin Man. There's so much fluid. Guys, there's so much fluid, it will start leaking out their skin. How much fluid do you think is in their pipes? None. And I know this doesn't make any sense. Their blood pressure will be 50 over dead. They don't have any volume where it's supposed to be. It is distributed elsewhere. How can we fix it? Pull it back in. I mean, I know that sounds, this is not rocket science, is it? If we had a medicine that can press that back into the vessels by constricting, what would it be? A vasoconstrictor that works on alpha-1 norepinephrine. Do you see now why I told you you needed to know the receptor. Look, they back there high-fiving. They were like, girl, I got it, I got it, I got it. Massive vasodilation. It affects the container, the vessels. So, if this room, no. No, she had blue. I ain't gonna do it. All right. If I put this in here, this is my container, right? And this is in here. How much pressure is on this? This is a set pressure, right? So, if I put this in this room, have I changed the size of the container? Yes. How much pressure is in there now? Nothing. This much pressure, I've changed the size of the container. I have brought it in. The pressure goes what? Up. If I change the side of the container, your pressure goes in the toilet. This is what's happening. You have vasodilated the size of your container. Your blood pressure drops. If I bring the size of my container in, your blood pressure goes up. That's how vasopressors work, right? How do these patients present? What are you going to see? Guys, it cannot be septic shock without what? An infection. If they ain't got no infection, it ain't septic shock. That ain't rocket scientist either. Well, it could, no. It could, no. It ain't. Don't let that mess you up on the test. Well, it's, no. If it don't say something about the pneumonia, the coughing, the sick, the white blood cell, I don't care, urinary tract infection. Oh, they had a traumatic, no. No. Have to have a source of infection to be septic, sepsis, or septic shock. When do we start the differentiation between sepsis and septic shock? The onset of hypotension. So, if I have developed hypotension, what is happening? My body is no longer able to what? Compensate. Right? At first, when I get sick, fight or flight comes in, right? Tachycardic. Blood pressure may be a little bit what? Elevated. How long can you maintain that? How long can I run from the bear before I pass out? Not long. Heart rate's going to be elevated, blood pressure's going to be up, temperature's going to be up, and I get sicker and sicker. I can't maintain 140 heart rate. My heart rate's going to give out. I can't breathe 40 times a minute. My lungs are going to give out. My blood pressure is going to start to what? Drop. My body can no longer compensate. You have gone from compensated to decompensated. The onset of hypotension, you might want to remember this, is the onset of septic shock, hypovolemic shock, whatever kind of shock you want to flavor it. That's the difference between hypovolemia and hypovolemic shock. Tachypnea. What about skin for sepsis? Might be fever on the front end. Might be what? Might be. So there's two different flavors of shock. What do you think they are? You might have heard this term. Warm shock, cold shock. Which one do you think is better?
Warm.
Yup. You in cold shock. That's not good. Tachycardia, shortness of breath. Does every patient have every one of these? No. What about, why do they have an altered LOC?
Infection.
Their perfusion is what? Low. So we had that ventilation, right? What kind of shock was it? Was it septic?
Yeah.
Yeah, it was.
Yeah.
And we tried our best to move that until after this, but it didn't work. When you guys are in clinicals, if you have the chance, everywhere has a sepsis bundle or a sepsis packet. You need to look at it. Guys, these are national standards. You have a certain amount of time to draw blood cultures. You have a certain amount of time to give antibiotics. And if you don't do that, then you get a nastygram and you have to be able to document why you did not do it. What are these? SIRS, Systemic Inflammatory Response Syndrome. Patient comes in and I'm going to say, I think they might be septic. How do I know? It's a score. So I'm going to look at several things. Are they running a fever? Are they tachycardic? What else? Huh? I can look at lactate. Respiratory rate. Do they have a possible site of infection? Because I'm telling you right now, I can go give myself 2 of these right now by running up and down the stairs. But I don't have a possible site of infection, so it's not SIRS, right? Fever, tachycardia, tachypnea. Now, if I do have 2 of these, or 3 of these, and infectious source that has been identified, pneumonia, urinary tract infection, whatever, it is sepsis. What is that word? Hypotension. Now, when you're treating sepsis, septic shock, you don't just jump to vasopressors. Why? You got to give them fluid. There's nothing in their vasculature. It's all out in the third space. You're going to give them a vasopressor. What you going to press on?
That's the walls of the vessel.
Yeah, that's it. You're going nothing. Their blood pressure, I'm serious, it is not going to go up if there's no volume. It's going to crackle, yes.
So what do you do with the fluid that's in the third space?
It will come back in once you get the blood pressure up, and you will start pulling it, and you will give them a diuretic.
Okay.
Because not only is it third space, where else does it go?
Cavities, heart.
Your lungs. They will also have hellacious pulmonary edema. Y'all talked about ARDS. What's one of the things that sepsis is a huge thing that leads to ARDS? Guys, we don't know why folks get ARDS. Some people do, some people don't. There is zero rhyme or reason. Sepsis is a huge risk factor for developing ARDS, and ARDS carries a huge mortality rate. Once they get it, it is so hard to get them off of it and to get them to walk out of the hospital. Once we said, oh, this person's going into septic shock and they have hypotension, we will try to give them cautiously 2 liters of fluid. Do you think that is written in stone? No. If your patient's BNP is 50,000, I am not giving you 2 liters of fluid. And you already got pulmonary edema. Guys, this stuff is not written in stone. You have to use your assessment. You have to use your clinical skills. If you could wring their lungs out, you're not going to give them 2 liters of fluid. You have to give them fluid. You have to. I have never seen that, and you know I say that very carefully, I have never seen them not give a septic patient some fluid. But it is not growing up in emergency medicine, it has been 30 milliliters per kilogram. That's a lot. Don't write that down. The normal, like a trauma, is 20. So that tells you how much more it was because they were third space that bad. But we found we were doing what? Flooding the patients, and it wasn't quite what we needed to do. Hey, we might want to look at this and just not put it a set number. After that, saline, if the blood pressure's not coming up, then we add what? The vasopressor. What's first line pressor for sepsis? Norepi. septic shock, what happens if you don't stop it? Mods. Guys, mods carries a 40 to 50% mortality rate. That is not good odds at all. Once it gets to that point, it starts shutting everything down. The kidneys, the lungs, the guts. What do you think the last thing is to shut down? The heart and the brain. Honestly, once it gets to the kidneys, that's when that 40 to 50% starts. I'm only going to mention this. This is not on your test. We will go into this heavily in hematology. There's something else associated with sepsis that's called DIC, and it starts right there in MODS. Disseminated intravascular coagulopathy. They start clotting and bleeding out of every orifice. It is horrible. Yeah, exactly. I've seen it once. I don't ever want to see it again. And it is associated with this in sometimes. But we will talk about that in the hematology. How are we going to treat it? What are our priority interventions? First one we can say is like every assessment that we're going to do, like monitors, SpO2. Really quickly, we need what? What am I going to get before my antibiotics? Guys, in these tests is a perfect world. This ain't going to exist when you get out. In this test, and I'm telling you this is a perfect world. You're going to get every blood draw. You're going to get every IV stick. I'm telling you that. You're going to get every antibiotic. You're going to get every blood culture before that antibiotic. So go ahead and get that in your mind. This is a perfect world. You don't have to wonder, well, what if I don't know? You're going to get the blood cultures before the antibiotic, because that's the way this test is written. I'm not trying to confuse you guys, because that could be confusing as hell, right? Well, I don't know if I got it or not. I am telling you, if there is a question that is that, you know you have drawn the blood cultures, or I will tell you that. This is like defibrillation with VFib. If you do not give them antibiotics, what's going to happen? They're going to die. It is very important that you give IV antibiotics. So what do they need? An IV. You need to get that IV. What is a priority? IV. Yes, you need blood cultures. Yes, you need the antibiotics. But what else do they need really quickly? Fluids. You might want to remember that. Yes, they need the cultures. Yes, by all means, they need the antibiotics. You have got to get, and I know a lot of these things happen in tandem. You walk in, and they're in the emergency room, they're in the ICU. Everybody's doing all these things at the same time. But you need the cultures, you need the antibiotics. They have got to have a fluid bolus, because their blood pressure is that low. You can't just run in and give them a pressor. Why do I need a Foley? Monitor that urine output. Y'all may not have ever seen one of these, and this is the damnedest thing. I don't understand why you have supplies that are life-altering and you don't use them. Does anybody know what kind of Foley I am talking about? It is a temperature sensing. And everybody's like, oh yeah, I've seen it. I had a septic patient, I was like, and we were doing clinicals, I asked her, I said, hey, do you want, no, I don't need it. And all my students were like, why? You have a septic patient. Why, if you got 500,000 of them in the, why would you not use it? I only got it anyway. I don't know how that got in there. Dadgummit, I told you not to do that. I wouldn't have done that. You need to monitor urine output heavily. Guys, that is the best. Do you know what, during mods, what do you think the first organ system to go is? The kidneys. If that urine output starts trending down, you need to be concerned. If you don't have a Foley, and I know nowadays they really don't like putting a lot of Foleys in, but still, this patient is going to have one. IV fluids, temperature management. Guys, we can't let their temperature go to 106 and stay there. They probably will have to be put on the ventilator because they're just that sick. You may have to do dialysis. If they get to the septic shock part, what sort of respiration have we said they've gone into? Not aerobic. What is their potassium? Through the roof. If it's that bad and they're getting to multi-system organ failure, they may put them on dialysis as a last-ditch effort. Vasopressors. Why corticosteroids? I mean, what is the basis of this? Inflammation, infection. What other test? Why did I put that on there? Hypotension and tachycardia. Yep, we're going to do those diagnostics. So we said blood cultures. What else? Somebody said lactate earlier. So if my lactate starts out 20 and now it's 10, are we going in the right direction or the wrong direction? Right direction. I want it to come down. What about my CBC? I want it to be normal. Guys, I told you, and I don't expect you to remember this, but this is the reason that we're drawing it, that H&H. I told you there is DIC that goes along with this. If you get it back and it's, oh my God, low, they're bleeding somewhere, that doesn't come along with sepsis normally. Why do I want a metabolic panel? Kidney function, and what else? I want to look at that potassium. I'll do a UA. I might want an EKG too, right? I didn't put this up here. You might see this. They might actually have a bump in their troponin. It's not going to be as high as a myocardial infarction. Why do you think that would happen? It's causing damage to the heart. Now, it's only going to be a little bump, but you might see that. They're going to draw a troponin on this because if it's a hellacious increase, how much has that affected their heart? What if their heart was sick before? Can you have two different kinds of shock? Yes, you can. So you had septic shock for pneumonia, and then it put a lot of strain on your heart, and now your heart has gone into cardiogenic shock because you had a myocardial infarction. They're not coming out of the hospital. Like I said, I'm not going over this because it's kind of confusing to wrap your head around that they're bleeding to death and clotting at the same time. Has anybody's dog ever done that? Yes, mine did. His nose swelled up. And I was like, and he still goes out there and tries to bite the walls. I'm like, you are so sick. What happens in this? It's not necessarily always a bee, but it is, bees, wasps, anything like that. What's another big one?
Peanut, shellfish.
Food, peanut, shellfish.
Meds. Meds.
Any kind of meds. Now, this is not an allergic reaction, right? What's the difference? Has to affect what? At least two body systems. A lot of times it is airway. It is an immune response. Once again, what's released? Histamine and cytokines. Remember I told you, inflammatory markers are released. They affect the capillary membranes. Everything starts leaking. What's the difference between this and sepsis? There's no what? Infection. This one has something on the skin that sepsis doesn't. Urticaria, which is what? Hives. You still have massive vasodilation. Your container is still getting bigger and everything's leaking out. You have hives, and it is in response to what? An antigen. I don't have an infection. So if they have an infection, it's not this. This also causes what? It causes bronchospasm. So with sepsis, you might have heard pulmonary edema, which sounds like what? What is this going to sound like mostly? Stridor or wheezing? This is still distributive shock. It just has different signs and symptoms. Fluid is still being distributed elsewhere. You still have a massive vasodilation. Do they have a fever? No. Their skin is just red and hot. Wheezing, stridor, shortness of breath, edema. Why do they throw up? You guys know?
Because of the smooth muscle silence.
Have y'all ever got like truly fucking terrified? Like I'm talking about scared or so upset that you want to what? Throw up. It's that flood of epinephrine and norepi, that fight or flight. You want to throw up. And it is that peristalsis, that smooth muscle. It's kind of everything all at once. Really bad anaphylactic. It was Wass, and he had actually done his. If he wouldn't have had an EpiPen, when we drug him out of the car and he threw up all over all of us, his blood pressure was 70/30 when we got him in there, completely altered. We had to give him IV epinephrine. You don't usually do that. Everyone whose blood pressure is low has always thrown up. But I think it's a combination of everything you just said. Being low sick, all this smooth muscle, and the flood of all the adrenergic neurotransmitters. What are we going to do? What is our priority interventions? I know assessment. Yes, ma'am. Can I get a hallelujah from the back pew? Epinephrine. I ain't going to ask God or nobody. You getting it in the arm. I am. Guys, that's NCLEX. Here's the perfect world. Yes, I know we have to have an order. Y'all can go ahead and assume, and don't throw nothing at me. I know what it makes out of you and me. You've got the order. That is on the test. You have the order. Give the epi. What is the emergency? Your airway is going to swell shut, starting here and going down. If this swells shut, there ain't nothing to cut. What you gonna cut? You just gonna cut their neck and they're gonna bleed because you ain't gonna get no tube down there. I'm dead serious. If you don't stop this, because the surgical cry goes here, all this is swollen shut. Where are you gonna put that tube? You're not. When they bring the snake into the emergency room, tell them to go back out with the live snake I really appreciate you bringing me the snake so I can see what kind bit you, but don't bring the live snake into the emergency room first. Don't bring the bag of peanuts with you.
Make the patient hold them.
The shellfish.
You can't make this stuff up. Is that the lobster? Yeah, this is the one that my son ate right at.
Maybe you can test it.
Why don't you go outside and eat it? I know we're laughing about if they have something that's on them that they're allergic to, please take it off. If they have, I mean really, if they have a stinger on them from something, don't squeeze it. Some forms, like especially honeybees, if they've got the little sac on it and you squeeze it, all that venom goes in you. They say scrape it off of them. Don't squeeze that little venom sac. Take the antigen away. Oxygen, IV fluids. Give them the epinephrine. There is a hair trigger for intubating them with an endotracheal tube. Why? Huh? Yes. What's going to happen if I don't get that tube down in there? It's going to swell shut.
Oh, I thought it was.
But if I, yeah, bye-bye. If I can get that tube down in there, then it can swell around it. We okay? Now, I'm not saying it's going to, but Murphy's Law, right? Everything bad that can happen will, unless you're prepared, and then ain't nothing bad gonna happen. And you're gonna say, I did all that for nothing, but that's okay. At least you didn't die. How often are we gonna do vital signs on a critical patient? At least every 5 minutes. You ain't leaving the room. If you do, we're gonna chase you down. No. IV fluids, oxygen, remove the antigen. Epinephrine, IM starting out. Guys, I'm not talking about an IV epinephrine, IV push. If this patient comes in and is hypotensive, which pressor are you going to use? Epi. I mean, if you're going to give it IM and they say, hey, I need you to give them a pressor, give them the one you were going to give IM. It still has the same effect on their lungs, and it still has the vasopressor effect. So give them the medicine that will help the most things. What antihistamine? Diphenhydramine and what? Huh? Diphenhydramine has been. How many histamine sites do you have? 2. 1 and 2. What else besides? We'll use the other name. Benadryl and what?
Circle.
Can we get a hand? Starts with a P.
Phenylephrine.
I bet a lot of y'all take this for upset stomachs.
Is it
Pepsid.
Pepsi. Oh, yeah, yes, it does. Is that going to be on the test?
If y'all see an anaphylaxis in the emergency room, you will see them given together. They have, this one works great. You won't see Pepsid given by itself for an anaphylaxis. Given together, an unbelievable effect. That nausea, vomiting, guess where that H1 is? In the stomach. Together, they make a really, yes, you need the Benadryl. If you got to choose, give them the Benadryl. But Benadryl is H2, Pepsid is H1. I'm just telling you guys the things that you might see. Antihistamines, corticosteroids. What's this? What's the name for it you might see? Solumedrol, Decadron, any of those. What's this?
Albuterol.
Alpha 2 agonist.
Oh,
I know it is albuterol.
No, we're not allowed to use that anymore, remember?
That's right, y'all ain't allowed to say that. So what if they tell you they want to do a neb? What's the other name for that? Well, I mean, is albuterol in what? Atrovent? Yeah, it is a type of, yeah. So, bronchodilator. Can anybody think, I mean, if it's bad enough, you might draw an ABG. But I mean, a CBC is not going to help you. If you draw a CMP to see if their potassium is high, they're probably dead. Can anybody think of a diagnostic? Huh? That would be like,
Yeah, that's after.
like I couldn't think of a diagnostic that we would do like on the front end. I mean, maybe when you got to ICU, I don't know. I mean, maybe if you had got bitten by something and they were looking to see if there was something in there, we'll reach it. I don't know why. And I know y'all probably think, Miss Thornton, I know it's easy for you. You've been doing this since Barney was a lizard. Lady, don't get in the weeds about this. The only way you can get neurogenic shock is trauma. It ain't no infection. It ain't no anaphylaxis unless you had anaphylaxis and fell down the stairs. And then that is a really bad day. Neurogenic shock is injury to the spinal cord up high. Your message center ain't messaging. The sympathetic ain't working. So what kicks in? And it causes massive vaso. Now, there's no cytokines, there's no histamine. But your nervous system goes haywire and it's not talking. It's basically not there. So, what are the signs and symptoms basically of most every other shock? Tachy? Cardia. Your heart rate's 30. Does that fit the picture of any other shock unless they're damn near dead? No. Their skin is hot and dry. Even if it's sepsis, their skin is what? Diaphoretic, cool, clammy, thready, pulse 140 is 30. Do you see what I'm telling you? It does not fit any other picture. MBC, thrown off the motorcycle 550 feet, their heart rate is 40. I can't move my legs. I'm not going to make it that easy. 40, hot skin. It doesn't fit any other picture. Period. Don't get caught up in the weeds. If you see trauma, now don't just assume, because I might make them septic if you go down that road. But if their heart rate's that low, now are they going to be hypotensive? Yeah, because their container's this big. What's the vasopressor of choice? Their container's this big. I need to bring it this big. Norepi. Have y'all seen like a pattern here? I mean, and I said something, what was it? One of my slides was wrong. What was it? Who told me that? What was one of the slides was wrong. Yeah, cardiogenic shock, I said vasopressin was second line. It is not. Vasopressin, if it is anywhere, is like third or fourth on any of these shocks. Cardiogenic shock, number 1 is norepi. Number 2 is dobutamine. I'm not asking y'all second line shock, guys. What's first line vasopressor on all of them? There you go.
Except for anaphylaxis.
Yes.
That's the only one
That's the only one. But why would you use anything else on anaphylaxis? Right? For neurogenic shock, you have lost the sympathetic part of your nervous system. This is a fight or flight. So parasympathetic takes over, which is everything is relaxed, which includes your entire container. Massive vasodilation. So if this is fight or flight and tachycardia and the parasympathetic has taken over, what happens? It's everything opposite from fight or flight. Guys, I cannot tell you how profound, and this is real world, how profound that hypotension is. Bradycardia, and they might have warm, dry skin up here and cool skin down here. It is very obvious the temperature difference, but that bradycardia, hypotension, and it does not fit the picture of any other shock. Do you have temperature differences in any other shock? Is everything. Everything's cool and clammy, everything's diaphoretic, or everything's hives and flushed. There is no temperature changes. If I have had such an injury that it has impacted my spinal cord, you need to do what? You need to immobilize that spine. This means a C-collar, this means a spine board, and you don't need to just be snatching them around because it might just be injured and swollen. And if you go to snatch them around, what might happen? It might completely transect the cord. And that means, especially if it's high enough, it's game over. IV fluids, they still need crystalloids, continuous monitoring. What kind of hospital do they need to go to?
Trauma.
They need to go to a trauma, a level 1 trauma with what specialty? They need neurosurgery. Guys, what specialty do we not have here? We do not have neuro anything. Nothing. They need radiology studies. Guys, an MRI is not an emergent radiology study. This is 3 days later. They're going to get a CAT scan. They're going to get plain films. Medications. Number 1 is norepi. Why are they going to get atropine? Bradycardia. Fluids. Why corticosteroids? What that spinal cord is not transected is swollen, right? So they might get corticosteroids. You might see neosynephrine, depending on where you're going to do clinicals. That is not first line. First line is what? Norepi. Anybody ever had a stuffy nose? What do you spray up it? Neosynephrine.
Oh, that.
What does it do? It vasoconstricts and then you can breath.
So what does it do in this case?
It is a alpha-1 agonist.
So like what
It's
is
a vasopressor, just like norepi. It is a 100% pure alpha-1 agonist. A lot of hospitals don't have it. But if you're at Skyline, who's at Skyline? If you were working in the medical ICU, you will see it. I didn't know they used it as much as they do. I don't know about trauma. Is anybody in trauma?
We're in the neuro.
When I was working at Vandy, y'all have to understand that was in 2010. That was the only place they used it. Because even norepi is not 100% alpha-1. Phenylephrine is. Obstructive shock. Something is getting in the way of forward flow. Either blood ain't getting in or it ain't getting out. That's it. What causes this? 3 things. PE, tamponade, tension pneumo. That's it. Blood ain't getting in, blood ain't getting out. What is Beck's triad? Y'all should have talked about this in chest trauma.
It's distant, parts down,
Yes. Because a lot of times you will not hear those muffled heart tones. If you sit there long enough to be like, I think that's muffled, your patient's going to be on the floor dead. Now, that hypotension and that JVD will be noticeable. Why does it do that?
Trying to push the fluid back.
Hmm?
Trying to push the fluid somewhere.
You okay with this? I'm going to have to hook you. Is that okay? So, here's the deal. Valentina's my heart, right? And she got stabbed, she got shanked. So she's got fluid building up and she's trying to beat. Every time she beats, she's like getting buried in the sand, right? Every time you breathe out, a little bit of sand comes in. I put pressure and I put pressure. Sooner or later, what's going to happen? She's not going to be able to beat. What's going to happen to that blood? It's going to back up and it's not going to be able to get in. And where's it going to go? JVD. How do I solve the problem? Draw the blood out. A great big long needle. You put it right in here and aim it at your scapula. Y'all don't do that.
No.
Pericardiocentesis, that's what fixes it. Usually done where? In the OR. They can do it in the emergency room. We had protocol to do it on Life Flight. I never did it except for in the cadaver lab. I talked to some of my cohorts that did it, and one of them actually said it worked. Guys, do you know how much space is in the pericardial sac? Like, I always like, hey, is he?
Like 30 of them.
So, frequently, if you were doing this emergently, you would go into the left ventricle and the patient would go into big tach. That is what stops this problem. Fluid is accumulating, the heart's going to stop what? Beating. So it's putting pressure, the heart can't beat quite right. So half of its output is getting out. Cardiac output goes. Blood pressure goes. Perfusion goes down. So this is obstructive shock caused from cardiac tamponade. Now, was that cardiogenic shock? But now the pump failed, right? That's not it. It's not for myocardial. It's not the heart itself. It's something that happened to the heart, right? It's trauma. Now, it can be medically induced from a pericardial effusion. You got sick, but that I would have to give you enough information to let you know there's fluid accumulating in the heart. Cardiac tamponade is cardiac tamponade. 95% of the time, it's trauma. But it can occur from medical illness. It can occur from cardiac surgery. It can occur from cancer. At the end of the day, it's fluid accumulating where blood can't get in, and half of it is getting out. So that's why you see JVD. Why are heart tones muffled? The fluid's there and it's not really water. And the hypotension because your cardiac output sucks. NCLEX loves stuff like this. Beck's triad, Cushing's triad, battle signs, Kerr sign, whatever signs you want to talk about, they love stuff like that. And you might want to remember what Beck's triad is for Mr. Lomax's and mine. So, if you have tracheal deviation, which one of the three do you have? Did I say a regular old pneumothorax? No, I did not. Is it always a pneumothorax? All right, y'all gotta commit. Who says yes? Y'all gotta commit. Who says no? Y'all didn't commit.
We did, thank you.
What other kind of hemothorax? Guys, you can get like 2 liters of blood in there. If you got all that blood in there, what's gonna happen? It's gonna shift. if you see tracheal deviation, sometimes that's a post-mortem sign. The second you see that shift, I'd say you have less than 3 minutes to get that hole in the side of the chest. That's what saves the patient. It ain't a chest tube, it's the hole. You have to let that pressure out. What's right in here?
Heart.
Everything that keeps me beating and going. It's not just your heart. What's right in here? Your great vessels. Aorta. Everything that pumps out, everything that pumps in. So if I start pushing against all my great vessels, oh, he's straining against me. He's strong. If I start pushing and pushing, what happens to, he's laughing at me. What happens to my cardiac output? It goes to crap. The blood can't get out. And now it can't get in either. So blood pressure is going to go down. Sooner or later you're going to die. How do I fix it? I want to get it back over here, right? So, arm up, 5th or 6th intercostal space, feel the rib, cut, punch through. That's it. That long. Guys, this ain't the sexy in the OR with the ultrasound, I'm a numbing up. No, this is you fitting to die. Is this a, you have to be paying a lot of attention to safety thing in the emergency? Guys, if y'all are in the emergency room and this is going on, y'all need to be paying attention to sharp objects because there's a lot of them. This happens very quickly. I don't want y'all to get stabbed. Attention pneumo. What might that patient look like if it hadn't got to tracheal deviation? Short of breath, bad. If I listen, what might I hear? Absent breath sound. What usually causes this?
Like esophageal tear.
Can be that. Trauma. Pretty bad trauma too. So if the patient comes in and they fell 20 feet off a ladder and landed on their chest, having a lot of trouble diaphoretic, breathing about 40 times a minute, and you see this weird thing on their chest and this going in and out, what is that? Flail segment. And you listen and it's absent. What has happened? Something's punctured something, and now you're starting to see this moving. But even before you got tracheal deviation, if you are not hearing breath sounds, what complication are you going to monitor for? That. Guys, every pneumo doesn't turn into that. Every pneumo, the breath sounds are not gone. It might be little. It might be a little bit diminished. You might not hear anything that's diminished if it's so small. If these are gone, you need to start watching and getting somebody's attention. That is a complication we don't want. That's the complication that kills people. Pneumo is air, right? Hemo is what? Blood. So, I don't put a lot of stock into percussion. If you think about listening, I'm trying to think how to say this. This might sound stupid. Where do people go to sing?
Church.
Open rooms, right? Well, yeah, but I mean, think about it. Where is the choir? In the open room, because we what? You want your church. But think about the choir. Where is the roof? Way up there. You want your voice what? To reverberate and to carry. There's this resonance. It's the same thing if you got all this space and all this air. You hear this hyper resonance. Well, what if it's filled with blood? It's going to be, and it's going to be this dull sound. Does that make sense? It's kind of like if it was a solid organ and you thump on it and it's the liver, it's just going to make this flat sound. If it's this, like you go out and you're at the Grand Canyon and you, hello, hello, there's this hyper resonance. There's air in there that's not supposed to be. It doesn't make that sound. Church.
Well, did you hear what I said when you kept looking? And I was like, to the Lord? Sorry.
I'm like literally crying.
Oh my God, that's so fun. Okay.
It felt right.
Church to the
My
Lord.
Lord, this must be
All right. Comes in. Sudden shortness of breath. What is hemoptysis? Coughing up blood. What's hematemesis? Is there a difference?
Yes.
Yes. Sudden shortness of breath. Coughing up blood. I went on a flight to Hawaii 3 days ago. I'm a female of childbearing age and I take birth control. Needs to get your attention. For any females that did not know that, that predisposes you to a PE, if you didn't know that. I think some of them are worse than others. Yes? If that is what is happening, what are we going to do? Huh? How do we treat it? Sometimes, yes. How do we treat it? It's a blood clot.
Oh, wait.
Thrombolytics. So, why can't the blood get in? Where's the clot? It's in the pulmonary system somewhere. So the blood goes right atrium, right ventricle, somewhere into the lungs, and it ain't going where? It ain't getting to the left, so blood ain't getting in. And it's going to start doing what? Backing up. If we give them a thrombolytic and get rid of the clot, what happens? Blood goes where it's supposed to be. It's still obstructing forward flow. Then we can go sing in church. Oh my God. So, interventions, they are very specific for each one. You ain't gonna do pericardiocentesis for a pneumothorax. Well, you can, ain't gonna do no damn good. Cardiac tamponade, pericardial, cardiocentesis, big needle, big syringe, tension pneumothorax. Did I say anything about chest tube first? I gotta get a hole in that chest to relieve the pressure. You're gonna put a chest tube. It might be a hemothorax. I need to drain the blood out, and we need to hook it up to suction. Pulmonary embolism. We're going to do thrombolytics. If it's big enough, they might take them to surgery to remove it. What diagnostics? CBC, CMP, of course, a lactate. Radiology, why ultrasound? Want to see the heart? You can see the cardiac tamponade, echocardiogram. Why else for ultrasound? I don't know if y'all have seen these in the ER. It might not have progressed to the part that it might be a PE. I've got a red swollen place on the back of my calf. They'll look for a DVT and they can see it with the ultrasound. What's a D-dimer?
When a clot breaks off.
It kind of looks for clots. Is it specific?
No.
It is not. It's kind of used as an add-on, but it is there. Like if you got all these symptoms, they don't just throw it away, they'll add it in. But it is not the end-all be-all. whole bunch of possibilities for medications. If we're gonna cut a great big hole in your chest, what might we give you, hopefully? I hope we're gonna give you some pain meds. If we're gonna stick a great big needle in your chest, we might give you pain meds. There's no way you can list all the medications that we might give you. We might have to give you a vasopressor if everything's so low. We might have to give you narcotics. We might have to put you on the ventilator. So pretty much any of the meds we've talked about may have to be on here. But specific to this one that we have not mentioned anywhere else are thrombolytics. And you notice I didn't mention one specifically. It will not be specific on the test. But thrombolytics is thrown in here because of the pulmonary embolism.
And the left inferior costal margin. Angle the needle underneath the rib cage no more than 45 degrees to the patient's skin and aim the needle towards the patient's left shoulder as you continuously aspirate the syringe. Short, quick jabs, as opposed to slowly advancing the needle, are required in order to penetrate the parietal pericardium and to not tent it against the visceral pericardium. Advance and aspirate the needle until fluid, blood.
So that's hopefully what you will do and not go all the way down into the left ventricle.
And the left.
So, what are the three types of distributive shock? Septic, anaphylactic, and neurogenic. How about obstructive shock? What causes it? PE, tamponade, tension pneumo. What questions do you have about this today? So, cardiogenic shock, norepinephrine, and dobutamine. Septic shock, guys, I'm not asking you for second line. Norepinephrine, hypovolemic shock, you're not giving them a vasopressor. You're going to give them fluid. For all of these, you will give fluid first. Don't let that trick you. You're not going to jump to a vasopressor first, period. For neurogenic, our world, norepi first. Anaphylactic is the one that's different. Epi is first. I did record that dosage this morning, and I'll put it online. I also put another practice dosage calculation. The answers are on there. Please do the thing first, then look at the answer. Yes, ma'am.
You said the thing of the test is a perfect world. Should we assume they're already getting fluids and then get the med on your exam? Like, we assume we've already found the fluids and then.
I won't do anything like that. If I'm asking you a question, there won't be any assumption that it needs to be that you have to make the decision.
Okay. I just want to make sure. Yeah.
Does somebody else have a question?
Scenario, you just say,
It's on D2. No, it's the one that's on D2. Yeah. There's a Dropbox that's on there, and so you just put the answers on there.